There are lots of metrics that can be used when we're trying to capture what is social well-being and social health. At the top, life expectancy is always the kind of key outcome we're trying to improve. But there are other metrics which help us understand how social health is happening in people's lives. When we look at things like housing situations, level of overcrowding, we look at employability and average income, we can look at violence and crime, we can look at developmental indicators, we can look at civic participation, whether that's in volunteering or in the proportion of the population who vote, for example. All of these are dimensions of social health and well-being, and different countries and different municipalities have taken different approaches. Also, there are lots of different ways in which people can measure well-being and social health. And in the UK, we have a well-being index, and it focuses more, I think, on the interface between psychological well-being and social well-being. So it's focusing on very much on people's perception, self-reported perception of their quality of life. But there are, as I put in the slides, many other indices that can be used. And there are cities across the world that are starting as municipal governments to think about frameworks for social health, to enable them as municipalities to think in a more constructive way how to approach the challenge of building social health in communities. So that brings me on to some reflections on interventions. In the UK, about a decade ago, we had a strong push from national government, from the federal government, to the 5 ways to well-being. And this was very much at that interface of psychological well-being and social health. The emphasis being on participation in society, engaging people in being physically active, connecting with each other, actively taking up learning opportunities, participating in civic society through volunteering and through charitable aims, but also connecting with their local community in terms of recognizing and noticing activity and what was going on around them. And there is an evidence base that underpins this, which demonstrates it does have an impact. These 5 actions have a measurable impact on psychological well-being, and through that also increase social resilience and social capital in communities, which leads then to better social health. The What Works Wellbeing Centre did various evidence reviews, and I've referenced a couple of these about what can have an impact. So when we look at how do you improve life satisfaction as a measure, there are 3 evidence-based interventions which have strong evidence behind them. Developing emotional skills across the life course, not just in childhood, but also in adult life, shown to be effective. Psychological talking therapies have been shown to be effective, and physical activity-based interventions have shown to be effective. And I will just share an anecdote. Some time ago, I used to work at Public Health England, the national public health agency for England, and I led on physical activity for the federal government and through PHE. And I was working with the public health minister, the Right Honourable Jane Ellison was the minister at the time. And she used to say every time we met, she has never met a lonely, active person. Anyone who is active tends to have good social capital and good social connections. And it struck me this was reinforced and links well with this evidence base. If you can get your population moving every day, you will get them to connect with other people. They engage with the environment around them, and they create and build their social health as well as their physical health. Social capital is another area where they looked at, and again, that physical activity evidence base was very strong. But what also came through in social capital, which is this idea of how people connect with their communities and act as a collective towards social good, was youth skills programs. Engaging young people in volunteering, in civic participation, is an important part of building that social health and social capital. In terms of structural and policy interventions, there are a wide range of these. Inclusive economic growth is a particularly important one. Often in municipalities, we think about economic growth that creates new jobs. But we often don't think about who are getting those jobs. So having a very intentional approach to economic growth, which creates jobs for the local community and creates social mobility, so that those that are living in poverty can access the jobs that will lift them and their families out of poverty and have a pathway through employment to succeed, rather than creating jobs for a commuter population who come in and do work and then go back out to a much richer and more affluent suburb of the city. So that inclusive economic growth is particularly important. Creating an urban infrastructure, and I focused particularly on cities in this slide, but it is true for more rural areas as well. Thinking about an infrastructure intentionally to build out crime, to build out obesity, to build in safety, to build in community cohesion. There is strong evidence base about how to do this, but very few municipalities have the headspace to be able to do it in an intentional way that builds social health. Using a health in all policies approach to consider decisions, particularly capital infrastructure decisions and strategic policy decisions through the lens of health is important. I should mention, countries like Bhutan are often kind of discussed in the context of social well-being, where the government made a decision that the social health of the population had to be considered in every policy decision. But it is rare to see that at a much larger scale in countries that have more economic factors in play, which often mean that these considerations are downplayed for economic growth ones. And then finally, thinking around granular evidence and data. One of the things that we've certainly learned as a city is that it's important to go deeper than simply communities of place. We have to think beyond simply thinking about inequalities in the context of poverty and geography, and think about communities of identity and communities of experience. That brings me finally to share some of the work that we've done with our Pakistani community in Birmingham, because I think it is a useful reflection of that final point about building social health has to be anchored in understanding communities and recognizing the diversity of communities, not just thinking of communities in the context of geography. Although our Pakistani community in Birmingham is geographically zoned in that many Pakistani people in Birmingham live in similar parts of the city, there are Pakistani people living all over Birmingham, and that's brilliant. It brings an amazing diversity of the city, but it means taking a simple place-based approach to the inequalities of our Pakistani community doesn't work. And that's where thinking about them as a specific community of identity is important. So in 2022, we published a community health profile. This is one of a series of profiles that we've done to look at specific communities of identity in more detail, to look at the evidence base around health inequalities, linking back to that strategy for the city and the key themes and priority areas we identified. And we looked at both local data and evidence, but also at some international evidence as well, to understand the health needs of individual communities better, and to stop using a homogenization of South Asian communities. Because it does a disservice to our Pakistani citizens to say, yes, they are the same as our Indian or our Bangladeshi citizens. There are very different health behaviors, there are very different health inequalities, and we underserve our communities by homogenizing them. So we included in our profiles a bit of a history of Pakistani community in Birmingham and when they arrived in the city, helping people to understand the languages being spoken, the faith dynamics and the geography of the community in the city. We pulled out from the evidence some of the inequalities that are more prevalent in our Pakistani community, both compared to the general population of Birmingham, but also in relation to other particularly South Asian communities. And these are presented both as an infographic, but also in the context of the report itself. And I just highlight on this slide particularly this example at the bottom where we looked at physical activity in different South Asian communities, highlighting that the proportion of men and the proportion of Pakistani men achieving 150 minutes of physical activity a week, that WHO recommended level that is so important to improving health, was only 40.8%. That compared to 52.3% of Indian men achieving the 150 minutes. Yet this is often blurred together. So by actually pulling this out and demonstrating this significant difference between our Pakistani population and our Indian population, we've been able to work with our Pakistani community to really try and understand what is causing this. And this is the context of the Pakistani community in Birmingham. So we looked at specific local data, but it just highlights the value of unpicking and understanding these communities of identity. But we also, in these profiles, looked at some of the drivers of social health and considered areas like overcrowding of households, unemployment rates, and educational achievement, because it is impossible for us to consider physical health and mental health without considering these dimensions of social health. This information also ties into the intelligence we have from our national census, and we now have a population profile tool which pulls out the census data as well available. But I wanted to end with just a couple of examples where we've worked with our local Pakistani community. Partially, I think, because it is important to reflect that for this audience and think about how we, Birmingham City, halfway across the world from Pakistan, are thinking about Pakistani people in Birmingham specifically and intentionally. But also that these projects have been very much co-designed with our Pakistani community, based in the society that they live in. And that is essential when we're talking about that connection between social health, physical health, and mental health. If we don't have an active conversation about social health, we'll design interventions that don't work because they're not taking into account the social environment around someone and the community in which they live in. We work with the Ashiana Community Project on a particular program working with Pakistani women around their health and well-being. And that's been fascinating because it's helped us better understand, particularly for older Pakistani women who often came to Birmingham as migrants many years ago, but still have relatively low levels of English and are struggling to engage with some of the general universal offer, but also they don't see it as culturally relevant. And so by working with Ashiana, with those communities, to really understand what resonates with them, what is going to help them connect with becoming healthier. We're also very aware that our communities are in daily WhatsApp and Facebook communication with friends and family back in Pakistan. So it's really important that we think about both the narrative in Pakistan as well as the narrative in England when we're talking about these interventions. And the Smart Women intervention on physical activity is a really good example of this, where we've worked with the community to help consider the language that we use in England around physical activity, where we talk about moderate physical activity. And moderate's a very white British word that doesn't necessarily translate into Pakistani languages. And working with these communities to work out how to describe the level of physical activity someone needs to be taking to improve their health. But also using things like traditional dance and dance of heritage as a way of getting people physically active that resonates and speaks to their cultural identity and their values. We're just in the process of commissioning a 3-year partnership with a community organization to continue this work and to continue to build it. But I share these examples because I think they are really tangible examples about recognizing that we cannot improve the physical health or the mental health of our citizens without considering the social health and the social health environment in which their lives are led. And by working together with communities, and particularly in the context of communities of place, communities of identity, and communities of experience, this gives us a different approach to understanding social health and how we can use it as a paradigm to make change, to increase the length of life, but also to increase the quality of those years lived for the future. Thank you very much, and I hope that presentation was helpful and will open up the conversation for today's session.